This is a case of a 35-year-old female who was diagnosed with Bell's palsy 2.5 years ago after having her second child. The ER doctor prescribed her 2 medications. She could not remember the names of the medications, but she believes one of the medications was a steroid. However, she only took these medications for 1 week because she was breastfeeding at the time. She then saw an ophthalmologist and an ENT doctor. The ENT doctor conducted a hearing exam and ordered an MRI, which showed no pathology. 6 months after the onset of her Bell's palsy, she developed electrical shock pain in her lower left jaw while washing her face. She saw a neurologist who recommended no treatment at that time. She also tried to treat the lingering Bell's palsy with acupuncture with minor improvement. She still has residual weakness of the left muscles of facial expression. She also states she has some left side muscle twitching and spasms around her eye from time to time, especially when she's tired. History of present illness. So the onset of this condition was 2 years ago. The location is the lower left jaw. The quality of the pain is shooting electrical type pain. The frequency is only twice a day when washing her face, and she has no other triggers. This pain lasts about 2 seconds. It's an 8 to 9 out of 10 on the severity scale. When washing her face, it's when it occurs. And modifying factors, nothing really makes it better, and what makes it worse, of course, is washing her face. For the headache history, she does experience headaches. 1 year ago was the onset. Location is bilateral or left temporal. Light sensitivity sometimes. The quality of the pain is an achy pressure pain. The frequency is 2 times a week. The attack duration is about 12 hours and severity is about moderate. She said the causation may be eye strain. She does wear contacts. Modifying factors that make it better when removing her contacts, and what makes it worse is at the end of the day. Her medical history is positive for Bell's palsy and a history of carpal tunnel. She only takes Advil as needed for medications and vitamins. She has seasonal allergies, and the only surgeries she's had is childbirth. For the social history, she does admit to having poor posture and holding tension in her neck. Her left shoulder pain increases with stress, and she is under stress right now with having young children and also working full-time. For the objective exam, normal appearance and communication. The exam of the head and face, there is a weakness that's apparent on the left facial muscles when the patient is speaking. For cranial nerve testing, all cranial nerves are within normal limits except for cranial nerve 7. Cranial nerve 7, the forehead wrinkling is weaker on the left side compared to the right. For the eye squint, the normal squinting, but left upper left lip raises when she blinks or squints her eyes. She also, when trying to grimace, the upper lip does not raise as much on the left-hand side. For the extraoral exam and palpation of the craniofacial muscles, the right-left masseter had a mild pain to palpation. Right-left sternocleidomastoid muscle also had mild pain. The right-left upper trapezius actually had severe pain when palpating, and the right-left anterior temporalis had mild pain. When palpating the TMJs, the left lateral condyle had a mild to moderate pain as well as the left dorsal condyle. Her max pain-free opening was 45 millimeters, and her right-left lateral max was 10 plus millimeters, and no joint noises were detected. For the intraoral exam, the inspection of the teeth alveolar and gingival tissues were all normal. Normal contact with mylar on the posterior teeth. Normal dental midline. Exam of lips and oral mucosa, hard tissue, soft palate, and tongue all normal. Inspection of tonsils normal, and exam of salivary function was all normal. In this case, I diagnosed trigeminal nerve disorder, myalgia, capsulitis, neck strain, and tension type headache. So for the treatment plan, I gave the patient myofascial protocol with avoidance therapy, thermal therapy, and stretch and rest position. I also recommended stretches for the neck, gave her a handout, and I discussed with the patient postural issues. I recommended physical therapy, and I like to reevaluate the headaches after physical therapy. I'd like to request an MRI report to determine if a brain MRI was taken. No treatment for her episodic neuralgia was indicated at this time unless her symptoms increase in frequency. She only has the pain twice a day. She understands that the pain increases in frequency, medication is the first line of action. Patient is not interested in taking medication. Well, what is Bell's palsy? Well, Bell's palsy is a form of facial paralysis resulting from dysfunction of the cranial nerve 7, which is also called the facial nerve. This causes an inability to control facial muscles on the affected side. Most people with Bell's palsy start to regain normal facial function within 3 weeks. So here's a picture where the left side of this patient is normal, the right side is affected. You can see that she's unable to wrinkle the eyebrows. She has the drooping of the eyelid and inability to close the eye, inability to puff the cheeks, and she has this drooping mouth and inability to smile properly. When trying to smile, you can see the left side is able to, but the right side does not. So this is the path of the facial nerve, and Bell's palsy usually results from edema due to inflammatory process that causes compression of the swollen facial nerve inside of the facial canal. So what does the literature say regarding treatment for Bell's palsy? So in a literature review by Zandian on current management of Bell's palsy, they concluded that corticosteroids are currently the drug of choice when medical therapy is needed. They also stated antivirals, in contrast, are not superior to placebo according to most reliable studies. At the time of publication, there was no consensus to the benefit of acupuncture or surgical decompression of facial nerve, and long-term therapeutic agents and medications for Bell's palsy are necessary due to the recurrence of intractable cases. So this study was actually published in January of 2014. And as you remember, this patient was given 2 medications, most likely a steroid and an antiviral medication. She didn't, however, take the steroid medication for the full amount of time. So this could have impacted the healing of this patient's Bell's palsy. This is a study that actually was conducted in July 2014, so several months after the prior review that I had discussed. And this study involved antivirals and/or steroids for Bell's palsy. This was a large Korean study with 1,342 patients, and they tested the effectiveness of antiviral agents for the treatment of Bell's palsy in addition to steroids. The degree of facial palsy was measured by using the House-Brackman grading system, which assigns patients to one of 6 categories based on their degree of facial function. So, for example, grade 1 is normal function, Grade 2, mild dysfunction, such as slight weakness noticeable on close inspection, or possibly a very slight synkinesis. Grade greater than or equal to 4 is a moderate palsy, and grade greater than 5 or equal to 5 is a severe palsy. A good outcome or complete recovery was defined as a grade of less than or equal to 2. So in this study, the medications were as follows. For adults greater than 16 years of age, they were treated with prednisone for 2 weeks, an 80 milligram dosing that was then tapered. And for children, it was much less. The antiviral agent acyclovir was administered for 5 days, or the antiviral famciclovir was administered for 7 days. Treatment with the steroid plus antiviral agent resulted in significantly higher recovery rates than for steroid therapy alone in patients with initial severe Bell's palsy, and a non-significant trend towards higher recovery rates in all patients with Bell's palsy in this study. So they concluded that antiviral agents may therefore help in the treatment of Bell's palsy. So this patient had developed Bell's palsy and still had facial paralysis, but she was here actually because of the pain that she was having in the jaw. So is there any kind of connection or any cases where a neuralgia, trigeminal neuralgia, has been associated with Bell's palsy? Well, there wasn't a lot of literature out there. However, I did find a case report of a 77-year-old female with coexistent trigeminal neuralgia and hemifacial spasm who had experienced Bell's palsy half a year ago. So this was a similar situation to our patient. This patient underwent microvascular decompression, and intraoperatively, the vertebrobasilar artery was found to deviate to the symptomatic side, and a severe adhesion was observed in the cerebropontine angle. There also the anterior inferior cerebellar artery and 2 branches of the superior cerebellar artery were identified to compress the caudal root entry zone of the 7th cranial nerve and the rostroventral cisternal portion of the 5th cranial nerve, respectively. So they did the microvascular decompression of both of these nerves, and postoperatively the symptoms of the spasm ceased immediately and the pain disappeared within 3 months. So it was discussed in this article that the adhesions may have developed from inflammatory reaction after the Bell's palsy, and the anatomic features of this particular patient were factors that generated this disorder. So there may be, because of the proximity in these nerves, could be some overlap in these conditions. It is a possibility.